Hello everyone, this is Veysel, CTO of Johnson Controls. Welcome to the webinar. In this webinar, we are going to cover automating cancer registries to overcome the data bottlenecks with AI-powered abstraction. This is a really exciting project that we have been working on at Johnson Controls lately, and we would like to cover why we are building such a solution and what is the latest status of this solution and what are the bottlenecks and what are the burden on healthcare providers right now. So because the main problem here is that despite the fact that the certified tumor registries needs to go through thousands of pages to abstract cancer registries certain data elements, they only get to find relevant records out of 4% of the time, which means that 96% of the time they spend their time to finding the needle in the haystack, and this is quite inefficient. So our goal by developing this solution, by automating the entire process, is that to reach a certified tumor registry level accuracy at scale, which means that you can do this on a daily basis, only by a minimal supervision, so that we can build registries that could be updated daily, reflect every patient's reality, and we do this with less fatigue, less churn, and far fewer errors. Let's get started. So what are the bottlenecks in oncology research, right? Because that's why we are trying to automate this process end-to-end with the help of AI-powered abstraction. The manual bottleneck, this is the first bottleneck, because certified tumor registries spend hours per case reviewing unstructured data, and it takes sometimes more than a year, and there is a huge delay when it comes to reporting all these registries and data elements, which means that usually this data that is reported to authorities are quite outdated, which is defeating the purpose of reporting all these data elements at the first place. So why previous AI solutions failed? Because we are not the only one trying to automate this. There are many other solutions who try to attack this, but failed miserably, because especially with the advent of LLMs, people try to solve this problem via LLMs, and Johnson Controls is there for the last 10 years to offer solution in similar problem areas in healthcare. And then the LLM is the thing that has been happening for the last 3 years, and then general purpose LLMs usually struggle with oncology specific abstractions that we have observed so far. Because cancer registry require regulatory grade accuracy, and it also needs to comply with the clinical regulations and guidelines, abstraction guidelines. So also the data is multimodal. By the way, I'm going to cover all these topics in detail in the next slides. Because of multimodal data, there are too many different data sources that needs to be ingested and understood and then abstracted and consolidated into a specific schema. That's why LLM itself usually struggle due to these specific issues. And then there are certain automation requirements, which I'm also going to cover, so that at the end of this webinar, you will also get to learn why cancer registry is there, what is the burden, what is the problem that we are trying to solve, and a short glimpse of how we attack this solution, and short demo maybe if we have time. Because there are some automation guidelines, or there are some reporting guidelines dictated by certain regulatory bodies, and you need to report certain data elements, and this requires longitudinal understanding of multimodal patient data. And human in the loop is a must here. Even if you automate end-to-end, if you accidentally let the model take the lead and then report everything without any human supervision, like all these reports are consolidated at a national level, so we may end up with a huge mess that would still defeat the purpose of having cancer registries at the first place. So that's why we need the ongoing audit, monitoring, continuous learning, and ongoing data quality via human oversight is needed. So let's get started with the cancer registry, because we would like to understand what cancer registries are, and not everyone who's watching this webinar may be not aware of why do we have cancer registries. So basically, cancer registry is a systematic collection of data about cancer patients, including demographics, diagnosis details, treatments, and outcomes. So these registries are there to serve as a critical resource for monitoring cancer patterns to improve patient care. So they are being collected to improve the patient outcomes at the end of the day. So on the upper right corner, you see a simple diagram to show this process, because there are stakeholders. Like at the bottom, there are stakeholders: hospitals, public health agencies, researchers, policymakers, patients. So that is the first stakeholder. Then, for instance, doctor detect a benign tumor on a patient in one of his pathology report. It is written over there, let's say. Then this hospital, this clinic needs to report this to different authorities. So they are consolidated at different levels, which I'm going to also cover. So there are certain governing authorities over there. In the United States, we call it NPCR, National Program of Cancer Registries. And each country has its own bodies. For instance, in Netherlands, I'm based in the Netherlands right now, it's called NCR. In Belgium, it's called BCR, and so on. And international, this is governed by World Health Organization. So why cancer registry is needed, as you can read on this page, because these registers enable the monitoring of incident rates, like how often, what type of cancer type occurs across the entire population, what are the survival trends, and then the effectiveness of treatments for certain population. Because if you have all this data, the better solution and better treatment solutions can be developed by physicians and scientists, right? And this also important, these registries are also important for public health policies, because it also, like, even the budget allocated for this kind of researchers can be defined by the level of statistics regarding the cancer patients, right? So that if the budget, if the policies are developed according to certain cancer type or certain weaknesses to attack, and then to ensure the quality of care, the cancer registries will be really helpful to be able to get a solid evidence to define these policies. And then the traditional processes, certified tumor registers are people highly educated. They are trained to extract certain data elements for each cancer evidences, and then they need to manually abstract this most of the time. This has been for over a few decades, this has been done by manually since the beginning, right? And they usually manually abstract all these documents. So, and when I talk about the cancer patients, imagine a patient who has a cancer journey, cancer trajectory for the last 10 years, right? Who is like to survive over there, and then he or she is getting still treatment, and probably thousands of records are already generated through this journey. And can certified tumor registry, CTRs, needs to go through all these reports to find evidences for each stage, for each data element that I'm going to also cover in the next slides. And the optimistic estimation is usually 2 hours per case. If there's like one patient can have multiple cancer type or diagnosis. So for each one case, it usually takes at least 2 hours, but it's still too optimistic because we are talking about thousands of documents. So at the end of this cancer registry, long story short, is improving the cancer outcomes and patient care quality. So let's see how this process works in detail. So as I said, at the bottom, there's a patient level. And then there's a reporting level on top of this, because the patients get treatments or diagnosed at hospital, clinics, etc. And then there are physicians and doctors and then healthcare practitioners over there who are supposed to assign the diagnosis, analyze all these documents, write all these documents, and then consolidate them, and then report them to the registry level. So there are 2 levels of registry over there, by the way. The first one is state-based cancer registries. We call them CCRs. And they consolidate all these reports from different care providers, and then they report them to another level, which is a national level. In United States, it is MPCR, and then NACCR. All these reports are consolidated, and then there's one big database for all these registries to be able to utilize for the reasons that I explained in the previous slides, right? Why do we need this? So the data from the cancer registries, that are all these collected data, can be used to answer the following questions. So, for instance, which cancers occur most frequently? What is the distribution of the cancer by age, by gender, by certain distribution of the population, or uh, or uh, or how is the frequency of cancer developing over time for certain population? Because if there are some underdeveloped regions, or right, in some population or in some neighborhood, maybe if there is a different frequency or different trend, different type of cancer developing over time, there might be other factors that are impacting this outcome, right? That's why if you have all this data, you can find an angle to attack these issues to resolve them. And then what kind of prevention or screening techniques or policies needs to be developed in that region. Sometimes there are some evidences to find like what is the chance of surviving certain cancer types, because not all cancer types have the same survival rates, as you know, and then the risk of occurrences are also different from population to population. So, and when you condense all this, you can develop a solution or policy to improve the quality of the care, and you can also monitor how good is the care provided for the patients. Maybe in different regions there's a different quality of care, and that's why certain type of cancer occurrences, like certain type of cancer types are happening in that region, or maybe the patients are not able to get the proper treatment in their region, so maybe they need to be referred to some other facilities, right? So that's why government bodies or regulatory agencies are using all this data to define this kind of policies while treating cancer patients. So we have different level of register system. This is US specific, but according to my own research, this is almost same across different countries and regions. So we have national programs, we have state level cancer registries, we have the reporting sources. So we have three main layers, and at the bottom there are patients, as I explained before, right? So these are all these boxes represents the different data elements and different verticals that needs to be collected and that needs to be reported. Usually the target is to report 90% of the cancers events, like 90% of these registries within 12 months. So that is the target goal. But usually in United States, the registries meet like the ratio of the registries, cancer registries meeting this target goal is around 14%. I collected all these statistics from a document, a report also published by the MPCR, by the way, because even like there was a large working group in 2021, I guess. So they gathered all these evidences, and then they ended up some stark statistics to show the gap between current situation versus ideal situation. So, which means that 86% of the registries are already falling behind, and then the registry authorities are usually dealing with the data that are 2 years old. So usually it is 1 to 2 years it takes to report all these data elements. So why there is a delay? Because the registry data is hard. So there are complex documents, different guidelines, stringent guidelines. There are compliance challenges as well. There are some major barriers. Most of the time, the reporting mechanism or reporting structure or reporting methodology changes. So it adds burden because you need to train CTRs, like a certified tumor registries, again with the new regulations. When I talk about the regulations, I'm talking about thousands of pages of algorithmic regulations, by the way, like what to do when. I'm going to cover them as well. And then usually there's a staff shortage over there, and because registrars must extract structured data from thousands of pages of unstructured clinical notes, reports, and imaging. So this could be pathology reports, radiology reports, and CTRs needs to be highly educated to be able to understand each one of them, because there are different criteria and different hierarchy between these documents as well. If an evidence found in one report, it needs to be confirmed by another report, and then the size of the tumor changes from cancer type to cancer type while you are trying to find the TNM stage, like a cancer stage. And the most striking finding for me when I read all these reports published in 2021 was that only 4% of the electronic pathology reports are actually reportable cancer cases, which means that when a certified tumor registrars has all the data, let's say that 1,000 PDF documents or imaging data, etc., that he needs to extract all these data elements, right? 90%, 96% of the time, he is not able to find any evidence to report, which means that this data highly buried inside all this huge pile of documents, and then most of the time they spend their time to find the relevant information. Even if they find, they need to confirm it with the other documents, and if they are lucky, these documents are already chronologically sorted, but most of the time this is not the case. So even the cancer registries system in the United States covered the 97% of the population. Registries, like a reporting mechanism, most of the time struggle. As I said, 86% of them are already lagging behind. So when we collect all this data, this is usually older than 2 years most of the time, which is really bad. So I mentioned briefly about the guidelines to extract certain data elements, because they need to extract cancer staging, cancer types, as they need to assign some terminology codes, they need to normalize them, right? And then for each data, for each cancer type, there are different staging guidelines. So in United States, for example, there are 3 main guidelines over there: AJCC Cancer Staging Manual, or SEER Staging Manual, or other principles or algorithms defined to assign all these codes, all these data elements for one single cancer type. And then even if there is a, we talk about a patient who have survived for the last 10 years, right, with even one single cancer type. So probably the cancer evolves through the time. So the reporting mechanism needs to consider this journey as well. So when they report certain tumor evidence for a TNM stage for a lung cancer patient, the rules might differ when it comes to breast cancer patients. So that's why we have all these kind of specific rules and guidelines to define how you can extract certain data elements. And when you change these guidelines, you need to train your staff again, which is another delay and burden and cost. And then why do we need all this normalization? Because if you don't normalize the data, you end up with a garbage, right? So because you need to normalize the data with certain medical terminology. That's why we have ICDO codes, we have histology codes to be able to normalize all these findings so that you can make sense out of this data. If you cannot normalize it, it's another problem at national level, right? So they need to analyze this further. So there's another delay if they try to normalize this themselves. This is one screenshot that we get from one of these guidelines, staging manuals. As I said, from on the left-hand side, you see as kidney staging form. On the right-hand side, you see two different types of sarcoma: soft tissue sarcoma and intestinal sarcoma. And as you see, T stage, like a TNM stage, as you know, there is a 3 different layers of staging, right? Like a tumor-related one, if I simply speaking, metastasis-related one, and then lymph nodes, right? Lymph node related ones. On the left-hand side, you see that if the tumor is less than 7 centimeters, it is T1, if it is kidney. But on the right-hand side, if tumor is less than 5 centimeters, it is T1, which means that if a sarcoma is 6 centimeters, it is T2 if you have a sarcoma, it is T1 if you have a kidney cancer. And then when you gather all these TNM stages, there is a summary level stage as well, like stage one, stage two, etc. For instance, over there you see that if it is T1 and N0 and M0, it is stage one. So normally people talk about the mean staging categories, right? When they say that it is stage two cancer, stage three cancer, these are all defined by the level of TNM stages. And then this differs from cancer type to cancer type, one cancer type to another. Okay. So when I talk about the data elements, luckily we have one popular ontology which is called MCODE. MCODE is a nice ontology which is called minimal common oncology data element. The goal over there was to build a consensus among different data elements to standardize this reporting mechanism. It's an open source data ontology, by the way, but it has more than 400 different data elements. It is being developed by a multidisciplinary group of SMEs. And then the goal is to bridge the current gap in the quality of cancer register data. Because if you don't have a guideline, if you don't have a standard, you will end up with a mess at national level or state level, right? So that's why this is a nice ontology that most of the reporting levels are using right now. But even there, as you see, this is a layered approach. So it's not one flat ontology. So it is group by, and then I highly doubt that CTRs report all of them in 2 hours, as you see. As you remember, I said that average time to report one case is 2 hours at the national level. But imagine yourself trying to do this in 2 hours for 417 data elements across thousands of records for a single patient. That's why there's a huge opportunity and gap over there when it comes to automate this process end to end by sticking to the guidelines. The data is not just the PDF that I talk, right, or just the reports, right? So data is multimodal, because when for any patient, it doesn't have to be a cancer patient, the data is multimodal. So it's collected from different sources. There are X-rays, MRI, CT, there are some physiological data, there are some lab results, sensor data, there are some medication applied, some discharge notes, some digital pathology reports, and so on. On the left-hand side, you see all of them, right? So there are maybe more than 50 different data sources over there collected for a patient. And for a cancer patients, it is more than this, by the way, because they need to do many other gene tests and some more scanning, more treatment like chemotherapy, etc. Right? So they have more documents than other patients most of the time. So this data need to be consolidated, and you cannot just pick any document, because there are guidelines says that this data element needs to come from this data sources and it needs to be confirmed by that physician, etc. So that's why you cannot just dump all this data into one single large language model, right? Even though there's a nice progress in AI research recently to consolidate all these data into multimodal large language models, but you still cannot put all of these into one single model or a multiple model, because of the reasons that I'm going to cover in the next few slides, by the way. Because there is a privacy concerns, so there is not enough benchmarks for certain data modalities, and then the models are biased, as you know. So there is no one silver bullet to ingest all these data sources. So finally, there's a burden on human, right? Because we have been talking about certified tumor registries since the beginning. So they are highly trained people, and there's a shortage of highly trained people. So if one CTR retires, most of the time it takes you need to hire 3 new, or you need to train 3 new CTRs to replace that experienced CTR. And then when you change the guideline and reporting mechanism, the abstraction time usually doubles. So there was statistics in the report that I read, by the way, in 2018, the specification changed, and then this doubled the abstraction time. Of course, after a few years, people get used to these new specifications, so the abstraction time normalize. But again, whenever something change, it adds burden again. So as I said, 2 hours per case, which is very optimistic. And one CTR can process 6 to 8 cases per day, if I do the math, right, a simple math. And then given that their annual salary is around 80 to 90K, so as you see, there's a huge opportunity over there actually to reduce the cost, to improve the quality, to improve the cancer registry process by avoiding all these delays, right? So before I mentioned that the data is multimodal and people tend to dump everything into an LLM to solve this problem, because now we are getting into how to automate this, right? So the one naive approach might be thinking that, okay, let's upload all this data into an LLM because LLMs are smart, AI is getting better every day, so why not I can just dump everything into one single model or a few models with, let's say, 1 million token, 1 million word context length, some frontier LLMs, right? But as you see from these charts, there is a context road that we call technically to show the impact of context length on LLM performance. This is why dump the entire chart into LLM wouldn't work, by the way, because as the context length increases, performance consistently degrades across all models. This is a recent research, by the way, done by Chroma. So as you see, when you hit 1000 token, it starts to degrade, right? So the accuracy starts to degrade. The things that you try to find inside the document gets worse and worse. By the way, y-axis is not accuracy here, but the information that you try to find out, because in cancer registry we try to find certain information, right? If I just upload 1000 documents, let's say 1000 pathology reports for a certain patient, and then give me all the TNM stages, there is no way you can make sure that the information that you got from LLM is correct, because the model performance consistently degrades. And then it just starts to jump from one fact to another if you just rely on the model's parametric knowledge. So that's why you need an end-to-end system here, which we try to build here. Now let's get started how we try to automate this patient registry process, oncology patient registry process, with multimodal AI, agentic workflows, and human oversights. When I say agentic workflows, I'm talking about a hybrid system that we are not just using LLM, but we are using end-to-end system, like from document ingestion to reporting, by also looping the human for the quality purposes. So I will cover. So it has 4 different components. The first one is data creation and extraction. And then the second level is patient level reasoning, because you need to do this at a patient level, which means that if you have 1000 reports, you need to report one result per cancer type for that patient. So how we ensured that we get patient level reasoning, I will try to cover. So I will touch upon, we have oncology specific agents and models. We fine-tune our own models, and we have different agents that are doing different things within this workflow. And we also developed an web application for this that you can install on your prem for automating this process end to end, because you need that UI to automate this abstraction process, monitoring the progress level, or talking to your patient data, and so on. We call it total patient journey, by the way, and patient registry workflow is only one module in total patient journey. Maybe in another webinar, I'm going to cover total patient journey application itself, but it's a perfect venue for such a task, by the way. At the end of the day, we tried to build a production test solution for oncology registries that any reporting mechanism can use. This is a one sample UI. Since the product is still in development, and we are adding new features every day because whenever we ship this product to different users, we get new feedbacks, and then we keep adding new features. For instance, this one shows some patients and their document timeline, and then each document comes from different domain and modalities, as you know. For instance, they have pathology reports, clinical notes, radiology reports, and then if I see a document timeline in this nice UI, I would be able to sort them, and then I would be able to make sense out of them. Maybe some of the documents are irrelevant for cancer registry purposes, right? That's why I can filter them, I can select or deselect all, and then start the data creation or abstraction process. So on the left hand side, you see a certain data elements that you can select, unselect, etc., because not all of them needs to be extracted manually, by the way. Some of these information, for example, birth dates, gender, etc., can come from EHR data, which are already structured data, but some of them needs to be manually created. That's why you can just select, deselect some of them, and then create your own processing workflow. And at the end of this process, hopefully you will be able to see such a UI, which shows that like one normalized value with their histology code and ICDO codes, with the date, like a diagnosis date, and some and all the TNM stages and so on. So imagine we do this for 400 different data elements. But the nice thing about this is that it is not just extracting this, because if it is if it says stage 2B, how would you know that it is correct, right? Because that's why we have human in the loop. And human, we need to provide some UI, some flow to human to optimize their workflow as well, so that they can just pinpoint this low confident evidences, low confident findings by models, so that they can jump in, manually review, approve, reject, etc. Right? That's why we wanted to return explanation and confidence scores, as well as contradictory and supporting evidences for each finding that we return on this UI. That's why if model says that lung adenocarcinoma, it needs to say that how confident he is, right? So as a user, I can set some threshold on the UI, and I say that everything that is below 80%, let's say, needs to pass through human oversight. Maybe I can define something like this, right? Or I can just manually review them and see which phrases, why the model picked that, arrived at conclusion. I'm going to show that in the next pages, by the way, because I need to, like for each patient, for each data element that needs to be reported, this is what our workflow returns. And over there, I also see the list of the documents for each data element. So if I hover, for instance, any data element, I will be able to see the evidences, the source of documents, like a source documents that have the evidences, supporting evidences, contradictory evidence for each one of them, so that on the UI, without going back to the original document, I can just open the corresponding document and then do the abstraction, or review the results, approve, reject, etc. Yeah, for instance, these are certain snapshots that I took from the application today. For instance, it says that TNM, like end stage, is CN0, and I explain what that means. When you hover that evidence, when you hover that findings that needs to be reported, it says that there are 4 supporting evidences and 1 contradictory evidence found for this stage by the model. So I can just go ahead and then click. Upper right corner, you see that what happens when I click. It shows supporting evidences, contradictory evidences, and each one of them are highlighted on the UI given the level of confidence scores. If it is contradictory, it will be highlighted red. If it is supporting, it will be green, so that you can maybe, as a human, when you read it, it doesn't make sense, and model might be misled by this as well. So even if the confidence is high, you can even reject that finding and then rerun it, or you can manually assign, right? So rather than thousands of reports to read, you can even check maybe the next sentence might have the information that you need over there, right? So for each data element, we have these supporting and contradictory evidences. And because we are talking about thousands of pages, like at least 2,000 page staging manuals, you don't even need to go ahead and then open them up and then review, because we already indexed all of them. So when we assign these data elements, these scores, we use all these guidelines as well. under the hood, and then you will be able to see the corresponding pages when you try to check why 4.5 centimeter tumor is stage 2 or stage 3 for that certain cancer type, because we will show the corresponding staging page, corresponding page from that staging manual as well, so that you will be able to easily use your own judgment and then change it. So this is how it looks like on the UI. So in the previous page, like 2 page before, so I show that we have the patient and then the tables for patient to report that includes the data elements to report. When you click on any data element, you see all the supporting and contradictory evidences and highlights. So let's have a short demo video maybe. It's just 40 seconds to show the flow, actual flow. As you see, I pick a patient on the left-hand side, and then these are the results that are coming for that patient, for that cancer type, like appendix cancer looks like he has. Now, if you hover any data element, you will see the supporting and contradictory evidences, and you can open up and then see inside, right? Let's see. Of course, in this demo, you only see the text document, but usually we have more than this. We even deal with XML documents most of the time, PDFs, DICOM images, and reports, right? So that's why if I just go forward, yes. So you see a short demo right now, and then this is how a human in the loop process works in our platform when the data creation process is done. So how we do this? How we accomplish this, right? We are still developing, but we already get some nice results, some benchmarks, by the way, which I'm going to show. So what we do is that we put all these encounters reports in a timeline in a chronological order, because in EHR there are structured data in EHR. Why we built total patient journey platform at the first place, by the way, without even oncology registry. Because we know that there is a data coming from EHR data, structured data, which is almost all the time the practitioners use via some like EHR softwares. But what we lack over there is the all unstructured data. They are not highly utilized. They are not harnessed, right? So, but there are some evidences only written, exist in unstructured notes sometimes. So if we explode all the information from unstructured documents, consolidate and merge with the EHR structured documents, and then put them in a timeline, we could have a layered summarization to handle thousands of pages while maintaining the context. Because we need to ensure the field level accuracy metrics while reporting all these data elements. That's why dumping the entire chart into an LLM wouldn't work. Because even if you do this, you have data from EHR, you have file reports, you have unstructured notes. Even if you sort them manually, even if they are there, if you just dump them, context rot happens. So you may never know what's happening. Because even the citation wouldn't work, right? If you just upload 100 page right now, just go to ChatGPT and then try to upload 100 page, and then try to find certain information and ask for the indexes, right? Ask for the phrase boundaries, like highlight. It will not even work, because it is not how LLM trained, right? If you ask what is the starting index of certain data elements, it may never be able to return that one. That's why we have small models to be able to handle this kind of evidence, finding the evidence, pinpointing them in the certain documents, and then grouping them together. And then if one patient has multiple cancer types, and then if you dump all documents without categorizing them by cancer type, and if you are asking kidney TNM stage, if patient also has lung cancer as well, some tumor evidences might be confused by kidney evidences, because if a patient has a tumor or some diagnosis at one level, probably in the next visit, this is going to be mentioned in the same documents as well, right? So for a patient who have multiple cancer types, their documents are messed right now, because there are many evidences coming from each cancer type. And then when you dump all of them into a model, into your workflow, even the smartest system would fail, because in some paragraphs it's talking about kidney, in another paragraph it's talking about lung cancer, and then you may never know which one is. If you split your document into different pieces, you may never know which pieces belong to which cancer type, and then the model will fail, and you will never have a deterministic pipeline. When you run it again, you will get another result probably. That's why we try to build some structured deterministic pipelines for such a critical data. So on the right side, you see the diagram, like a software diagram that, or architectural diagram that we use in one of the components in entire total patient journey platform. So for the cancer registry, we built such a simple diagram. It looks simple, but it's more complex here than this, by the way, because we have different lists, we have different size of models, we have different level of agents that are responsible for doing certain things. Some of them are only extracting TNM stage, some of them are only checking the guidelines to make sure that the staging is assigned correctly according to that cancer type. There are certain agents who are only dealing with processing PDF documents. Some of them are processing DICOM files. So it's a complex file. And the most smartest thing maybe we have done here is that reducing the context size that you need to feed into different size of models. Why? Because there is too much noise, as I explained before, when you try to process 1,000 of pages, right? Maybe some phone conversation that has nothing to do with cancer. Maybe the patient is administered for another diseases that has nothing to do with cancer. So that's why if you just filter all these documents by 10%, right? I mean, from like a 1,000 documents can be reduced to 100 documents if you just filter them by the oncological evidences, and then even this 100 document can also be shrunk into 10 documents, right? Why? Because there are many sections over there that are repetitive, that are irrelevant when it comes to cancer. So if you do this wisely, the burden on the next level in this process will be lighter. So, and then the accuracy will be higher, of course. So that's why we develop some narrow role-specific agents to reduce the context and raise the accuracy over the longitudinal patient views. Then, when everything is done, you can easily click, like you can easily report to registry levels with one click on the UI. That's why we have a UI on top of this as well. What kind of models that we have to inside this architecture is, for instance, recently in June 2025, I guess, there was a paper talking about how to fine-tune small models for detecting cancer types, stage, prognosis, etc. Even if there are more than 400 different data elements, the most important ones are if you can, detect cancer type, stage, prognosis by just looking at the node. How good all these models, even the state-of-the-art models. So they tested with one, they fine-tuned one small model, Llama 8B, Llama 3.18B, and then compete with the GPT-0 mini and GPT level models, Mistral, some open source models, right? So they tried to test with the state-of-the-art open source model at that time. They fine-tuned, and then their finding is their state-of-the-art accuracy is 76% right now across three criteria, three classification tests: cancer type classification, stage classification, and prognosis assessment. And you see so you can go ahead and read that paper, by the way. So what we did is that, okay, what if we check the frontier models, like Anthropic Sonnet 4.5 and GPT-5 are the latest ones, as you know. So they are doing really well without even fine-tuning, because their capacity is higher, generalization power is higher. They are probably 1,000 larger than Llama 8B, or more than this maybe. That's why it's normal that we get this kind of use. Then we pick one of our reasoning models, like 30B size of model, and then we fine-tuned with oncology, which we already fine-tuned with oncology data, by the way. So far, we did continual pre-training and then applied some fine-tuning for certain tasks for abstract, so for cancer registry. And then even 30 billion size of model can do better than GPT-5 and Sonnet 4.5, which is probably more than 100 times larger or 1,000 times larger. So which means that if you fine-tune, or maybe even if you have a budget and computation power, continual pre-training over your own documents or your large corpora, you would achieve better accuracies than out-of-the-box model. And then everything is on-prem, by the way. By the way, maybe I forgot to mention, everything that I mentioned about total patient journey and automating the cancer registry process can be run locally behind your firewall with no internet connection, because everything that we do here is developed by local models, and that you can install on your on-prem. The software itself can be deployed locally, and then the model can also be deployed. So if you only have one GPU with, let's say, 100 A100 80 GB memory GPU, let's say you can deploy such a model, and this is what TPJ needs to do many other tests, by the way, because we are using the same model for the other purposes as well. That's why we are using adapter layer on top of our base model for different tasks. We have small models as well, like 3 billion size of model, 2 billion size of model. We have small NER, which are less than 10 MB, by the way. I mean 10 million parameters. Okay, so their only job is to find the relevant documents, so that when it comes to LLM level, all these documents need to be filtered in advance by small models. So the impact, what we try to do in this process, right? We are trying to automate the entire cancer registry process by reducing the time required for this abstraction process by 98%, because we talk about 2 hours per case right now, right? And it was very optimistic. So we aim to handle one case in 2 minutes, and we are very close to that number right now, which means that we can achieve 98% efficiency while automating this. And then if I just do some math to find some financial, metrics, given the rate and salary and time, it's like almost $1 million per year, per 20,000 cases per year, given the rate of the CTRs, etc. So the cost reduction is almost 80% if you try to automate this for 20,000 cases per year. So again, what we are trying to achieve here is certified tumor registrar level accuracy at scale, so that it can be done on the fly while you are sleeping. This abstraction can happen, and as a CTR, when you sit on your workstation, you only deal with the problematic cases. Even if you do this everything still manual, let's say, you will not need to parse through thousands of documents, because all these irrelevant documents are already be filtered. Even if you would like to do this manually, you will still achieve this way less than 1 hour per case, hopefully, so that you achieve far fewer errors over there. Thanks for joining this webinar. I hope you enjoyed. Please reach out to me if you have any question. I'm highly active on LinkedIn. You can just connect me, or you can just email Johnson that's to me if you would like to get more information. You will have the recordings and decks as well, by the way. And then we will have several other webinars and workshops regarding the same topic. I even discussed this topic in our NLP Summit as well. So I hope you enjoyed the topic, and I hope we would help you to develop or automate this kind of workflows in the future. Thank you.